Good morning, everyone. This is Michael Hogue, APhA President, and welcome to this week's discussion on addressing the COVID-19 crisis. This is our weekly open forum for pharmacists designed to bring you the latest and late breaking news that's existing in the profession related to COVID-19. As I said, I'm APhA's president, and I'm joining you from Loma Linda University. And joining me today are some outstanding folks that I know that you will not want to miss, and I'm excited that you all are here to listen to the discussion today. Now, before we begin, let me just cover a couple of things for you. First of all, we have gotten lots of questions on APhA's Engage platform and social media about the medications that are being used to treat COVID-19. There's been quite a bit of new information released about this in the last couple weeks, so we've asked Dan Zlot to talk about that today, and we've also thought that you all would find it quite interesting to hear from one of the first pharmacists who's done COVID testing in the U.S., so we'll talk about that as well. Now, if you'll back up one slide, I want to do an appropriate introduction of Dr. Zlot. Dan Zlot is Vice President for Professional Education Resources at APhA, and he'll discuss the medications. Now, Dan's got a great background as a clinician. He worked for many years at the National Institutes of Health. He's an oncology specialist and understands immunology to a great degree, and he's really given us an in-depth perspective on these medications as we've looked through this COVID crisis, and we can't wait to hear his updates today, which I guarantee you will be the latest scientific information and great information for all of you. Following Dan, we are so excited today to have Dr. Beth Bryan with us. Beth is a pharmacist and the owner of Sirgoinsville Pharmacy and the Pharmacy Grill in Sirgoinsville, Tennessee. Now, Beth started her career a long time ago in pharmacy as a pharmacy technician working in an independent pharmacy in her small rural community, and then went to pharmacy school at Wingate University. Then after pharmacy school, worked at Walmart as a Walmart pharmacist. In fact, she married a pharmacist. Her husband is a Walmart pharmacist and works there now. But Beth took over as the owner of the Sirgoinsville Pharmacy in 2012, and she has really been on the cutting edge of clinical services in her rural community. In fact, Sirgoinsville Pharmacy is the only place in her town where healthcare can be received. She's the only healthcare provider available in her community in Tennessee. And so she has really taken a personal pride and really pushed hard to be able to be the resource that her community needs her to be. And we're very proud of her practice. And I just want to say also that we found out about Beth's practice in her pharmacy through some collaborative work that we've been doing with NCPA. And NCPA and APhA, as you all know, have been working very closely together on initiatives with the FDA. And we found out about Beth's practice when Doug Hoy, CEO of NCPA, shared her practice on one of his daily emails. And so we're always happy in the profession to be collaborating together with our sister pharmacy organizations. Now, Beth is one of the first pharmacists in the United States to offer COVID-19 testing right at her pharmacy. So I know you all are anxious to hear from her and hear about what's going on in her practice. But before we go there, I want to first just turn the floor over to my good friend Dan Zlot, who's going to share this clinical information, important clinical updates with you on these drugs. And one other thing to mention, we also have on today's program, as we have in our previous programs, Elisa Bernstein. Elisa is Senior Vice President of Pharmacy Affairs, Pharmacy Practice and Government Affairs. And as all of you know, Elisa's had a very long career at the FDA for 30 years prior to coming to APhA. So she'll be available for us also, and she'll give us a little update at the very end on some late-breaking changes that have been happening with regulations and so forth related to pharmacy. So Dan, we're happy to turn this over to you and tell us what we need to know about these drug therapies.
All right. Well, thank you, Brian, and thank you, Michael, and thank you as well for joining us today. Good afternoon and good morning, depending on which part of the country you're in. We're going to run through a lot of information really quickly. I'm going to give you a high-level overview. Do know that there's more information available on APHA's COVID-19 webpage for you if you want more detailed information that covers any of this. So let's start off with the drug that really kicked this whole thing off, and that's hydroxychloroquine. The initial claims regarding the efficacy of hydroxychloroquine really came out of a study that looked at hydroxychloroquine and azithromycin, and it was a non-randomized controlled trial, and it looked at the rates of viral clearance in patients receiving that particular combination, hydroxychloroquine and azithromycin, and they found that there was an increased rate of viral clearance compared to their non-randomized controls. So that was where we started. But there was no clinical information in there, so it didn't talk about how patients actually did, aside from being able to clear virus from their systems. So the same group then presented an expanded look at their data, 80 patients. It was very descriptional only. There were no controls. There wasn't even a control arm in that particular study. So, you know, it was okay data, but descriptive. So now we've started to get to the point where we're starting to see some randomized control trials. So I've got 3 trials that we'll give you high-level overviews of today, as well as a brief look at some new information that has been certainly in the media a lot in the last day or two, and that's some data coming out from the VA, and that's a retrospective analysis of their patients receiving hydroxychloroquine. So let's go ahead and take a look at the next slide. So the first study was a randomized control trial in 30 patients, and this was all 3 of the randomized control trials I'm going to talk about were done in China. So one important thing to realize is that all the patients in China were receiving multiple COVID-19 directed therapies, a number of different antivirals, lopinavir, ritonavir, something called Arbidol, which is an antiviral available in China and in Russia, mostly targeted at the flu. They were including interferons, ribavirin. So they were throwing all kinds of different antiviral agents at these patients. That's a huge confounder in all of these studies and doesn't necessarily correlate with the way that we treat patients in the United States. So you have to take the findings here with a grain of salt, to say the least. But that said, let's go ahead and dive into what the studies found. So the first study was a 30-patient study, 15 patients in each arm, the control versus hydroxychloroquine, and they found no difference in time to viral clearance between the hydroxychloroquine group and the standard of care group. So very much counter to what the initial study said. So the next study was a 62-patient study, again, one-to-one randomization between hydroxychloroquine and standard of care. And in this study, we actually saw some clinical benefit. They found statistically significant improvement to the time to resolution of symptoms, and they define that as normalization of body temperature, as well as resolution of respiratory symptoms, so cough, shortness of breath, tightness in the chest, etc. And they also found a significant, statistically significant increase in the number of patients who demonstrated an improvement on their chest CT. So when they looked at the findings of pneumonia, and I don't know if you have seen in the literature at all some of the pneumonia findings, but they are gnarly. They're impressive, to say the least. And so they saw really significant improvement in the pneumonia findings in this particular study. So a study, but perhaps suggesting some benefit to hydroxychloroquine. So then the last study, randomized study, was 150 patients, and they found, again, randomized one-to-one, 75 patients hydroxychloroquine, 75 patients standard of care. And what they found was that there was no difference in time to viral clearance. So again, another study that suggests that the hydroxychloroquine doesn't really do much in terms of increasing how quickly people get rid of virus from their bodies. And they also found in this study that there was no difference in clinical outcomes in their full population. And so they did a number of subgroup analyses, and what they found is somewhat interesting and maybe applicable to us in the United States. They found a statistically significant benefit in patients who had not received other antiviral therapies. So that's more in line with how we practice in the United States. When you look at COVID-19 patients here, they tend not to be on, 4 or 5 different antiviral medications, as is the common practice in China. So a lot of unknowns there, probably more questions opened up than questions answered there for us. So that's what we know so far. Now, the other study I mentioned is this new VA study that's been swirling around. It hasn't been published yet, so this is all non-peer-reviewed data. But what they found is that there was an increased risk of all-cause mortality in their hydroxychloroquine group. So they divided their patients into 3 groups: a hydroxychloroquine group, a hydroxychloroquine plus azithromycin group, and then a no hydroxychloroquine group. So it's not exactly a controlled trial, but they sort of use their non-hydroxychloroquine patients as something almost like a control. So as I said, they found increased all-cause mortality in the hydroxychloroquine group. They found no difference in mortality in the hydroxychloroquine azithromycin group compared to the non-hydroxychloroquine group. However, when you read the full paper and you get into the discussion, it turns out that there's a significant difference in these groups, a statistically significant difference amongst these groups. So this was a retrospective study. It was not prospective. There were no controls. And what they found were that the patients who were prescribed hydroxychloroquine or hydroxychloroquine and azithromycin were sicker patients in general as compared to the patients who didn't get hydroxychloroquine. So they may have had a worse prognosis at baseline. So without the proper controls, it's very difficult to assess this, but I suspect in the media you're going to hear a lot about hydroxychloroquine actually made people die in this one study from the VA. So when you hear that, keep in mind that it's because this is not a controlled trial. And so the patients who got hydroxychloroquine got it probably because they were sicker. And that's what the authors suggest in the discussion section. So bottom line for hydroxychloroquine, we still need additional data. Next slide, please. All right, well, now let's take a look at remdesivir. So remdesivir is another drug that has gotten a lot of attention. Early case reports for remdesivir showed a lot of promise. However, still no randomized controlled trials for remdesivir at this point. Currently, the best data comes from the compassionate use experience where Gilead, who makes remdesivir, has made that available to various institutions to treat patients on a compassionate use basis. In exchange for providing the drug, the hospitals and physicians supply data back to Gilead so they can see how these patients do. So they've right now reported out on 61 patients total who have received remdesivir. Data was only available for 53 of those patients. Now, this is a different patient population than we've seen before. So when you look at the demographics here, 57% of these patients were on mechanical ventilation at baseline. So that's a significant population deviation from what we've seen before. Usually you don't see that many patients who are on mechanical ventilation as part of your inclusion criteria for a clinical trial. 8% were also receiving ECMO, extracorporeal membrane oxygenation. That's a very aggressive type of supportive care. So that's our patient population. So within this patient population, 68% of patients showed clinical improvement, and of the patients who started off intubated, 57% were able to be extubated over the course of the study. 13% of patients succumbed to the COVID-19 disease. So because this was not a controlled trial, it's very difficult to make any analysis on this. We don't know what would have happened if these patients had not received remdesivir. So it's not fair to say that the remdesivir was necessarily responsible for these outcomes. It may have been, but there's also the possibility that it was not. So bottom line here, we still need a lot of additional information before we can make a determination about the effectiveness of remdesivir. Next slide, please. All right, so this is another medication that's received a fair amount of attention, and this is tocilizumab. So just some background, it turns out that many of the severe symptoms of COVID-19 disease are actually thought to be due to immune-mediated organ damage. So it's not so much the virus itself that's causing damage to the organs, it's our immune system's response to the virus that's causing some of this organ damage. And in particular, we've also seen evidence of something called cytokine release syndrome, which is basically an overly potent immune response where you get all these pro-inflammatory cytokines being released. And we've seen evidence of that in COVID-19 patients. So tocilizumab is an anti-IL-6 receptor monoclonal antibody. It's typically used to treat autoimmune disorders, and it's also found a kind of a niche use in something called chimeric antigen receptor T cell therapy or CAR T therapy. And that's another disease state where in the course of treatment, a lot of patients end up experiencing cytokine release syndrome. And tocilizumab does this perfect job of suppressing that cytokine release syndrome without suppressing the overall immune response. And that's really important for COVID-19. And we want to suppress that overly potent immune response, but obviously we don't want to shut off all immune response because our body's trying to fight off a viral infection. So that's sort of the background as to why people are throwing tocilizumab at patients who are experiencing moderate to severe symptoms of COVID-19. So all of the available data here comes from case reports or uncontrolled trials. The case reports do suggest benefit, rapid reduction in fever, resolution of respiratory symptoms, decreased oxygenation requirements, and improvement in chest CT findings. But once again, these are all anecdotes. They're all non-controlled trials or non-controlled data. And so, as is so often the case with COVID-19, we still need additional data to be able to make determinations here. Next slide, please. So we have some breaking news. Actually, this was just released late Tuesday night and was kind of made available to the public early Wednesday morning. The NIH has released COVID-19 treatment guidelines. So I highly recommend that you check these out. It's probably the best review of available literature that I've seen to date if you want to see every aspect of COVID-19 discussed, reviewed, and look at what some of the key literature pieces are so you can look them up yourself. This is the place to go. And a spoiler alert, so if you don't want to know the ending before you actually go take a look at it, turn your speakers off for a second. Now you have your speakers off if you don't want to hear. There is no good data to support the use of any agent in the treatment of any aspect of COVID-19 right now currently, aside from traditional supportive care stuff that we would do anyways. So as data matures, I think we'll get more information here. And as we get some of the better designed randomized control trials, this will be updated and we'll get more information. But we will provide a link to the NIH COVID-19 treatment guidelines in APHA's COVID-19 resources pages so that you can go check that out. And with that, I will turn it back over to you, Michael. Thank you very much.
Thanks so much, Dan. That was a great overview and a really great update on where we're at with treatments and the references that you'll see provided. Again, I want to remind everyone today's handout was provided to you in the handouts tab on the GoToWebinar control panel. And we also want to encourage you all that if you have questions today, type them into the chat box. We'll receive those questions, and then when we get to the Q&A section, I'll call on you individually to ask your question if you have audio and are available to do that. By the way, those of you who are wanting to ask your question verbally, be sure that you have entered the audio PIN number if you've dialed in on a cell phone so that we can hear you at the time that we open your line. Now let's talk to Beth Bryan about her experiences as a frontline community pharmacist and what she has learned in Tennessee. Beth, thanks for joining us. We're gonna share webcams so we can see each other and the audience can get to meet you a little more virtually. Welcome.
Thank you. Welcome to Tennessee.
All right, great. Well, before we get into COVID-19 testing, Beth, you've been doing CLIA wave testing in your pharmacy for quite some time. Can you tell us just a little bit about that?
Sure. So we've been doing CLIA wave tests since 2017 because we are the only healthcare in town. We started with doing strep and flu because we have a couple of schools nearby and some industries. So we started with those two tests because it made sense in our area. And then we're fixing to start the diabetic prevention program and some diabetic education. So we're going to start with doing A1Cs and things like that as well.
Okay, great. Now, maybe I should back up just a minute. What exactly is a CLIA waiver? Most of us on the line today have heard about CLIA waivers. That's come around with the COVID testing. What is a CLIA waiver and why is it important for COVID testing?
So CLIA waivers are managed by, let me back up. CLIA waiver stands for Clinical Laboratory Improvement Amendments. Those are registered through, or I guess you've got to register through CMS. And you need those in order to do point of care testing. and there are about 14,000 plus tests that are available. They have to be easy to use, low chance of mistakes or error. They're rapid, so that makes it perfect for the flu test, the strep testing, UTI, A1Cs, things like that. It's going to be great for the COVID antibody test. So I highly recommend, if pharmacies don't have that, to go ahead and get in process of getting their CLIA waivers.
Okay, great. Getting CLIA waivers is an important step. I would anticipate that another important step you might have taken along the way is some collaboration with your public health officials and public health departments. Can you tell us about that? What did you need to do before you started COVID testing in terms of that relationship?
So in our area, we reached out to our health department, and that's where we discovered the need in our area for testing. We had a shortage of tests. We had a shortage of testing sites. So when the outbreak occurred, we started on this project right then and there. So we were actually in the works for about a month, working with a local university trying to get a CPA. So when HHS released that we could order and do the test, we were pretty much ready to go. So we reached out pretty much to everybody.
Okay, so when you talked about a collaborative practice agreement, did you need a collaborative practice agreement to be able to do the COVID-19 testing, or tell me a little bit more about the logistics there?
We were looking at a collaborative practice agreement just like we do with our point of care testing, just because we needed a physician to refer if somebody did test positive and we didn't have the authority to order the test. So that's why we were working on a CPA. And then once HHS released that we could order and give the test, then we were able to do that on our own.
Yeah, so really you didn't have to have a collaborative practice agreement in place. Once Department of Health and Human Services issued their order, you were now able to do this without any additional CPA.
Exactly.
Okay, great.
Yes.
And what about the Board of Pharmacy? So you collaborated with the local health department. Was there anything special you had to do with the Tennessee Board of Pharmacy after the HHS order in order to be able to do this testing?
Not really with the Board of Pharmacy, but we did check with our state laboratory board because we have a relationship with a lab, and as long as we are working with the lab and doing the tests according to their protocols, then everything's fine with that. Once we do antibody testing, though, we will need to add that to our CLIA wave test that we're doing. So that will be another step there. But as long as we're doing the lab protocols the way they want us to do the testing, then the state laboratory board is okay with that. So everybody's going to need to check, with their state on what they're going to need to do.
So whatever testing you're doing, you essentially, if it's CLIA wave testing, Tennessee at least requires that you have to let them know what CLIA wave testing you're performing so that they're aware of it. I would suspect a lot of states probably do.
Yes.
Yeah.
Yes. So everybody's going to have to do their own due diligence with their state board of pharmacy or their state laboratory boards and see, if it's going to be different for every state. Okay,
great. Well, now, pharmacists have heard about this opportunity to do CLIA wave testing. What does a pharmacist need to consider? What do they need to think about before they jump into this? Are there some things that you've learned along the way that maybe they need to think about proactively?
Definitely. So definitely going to have to think about the state regulations and rules, how it's going to affect their workflow. So if they don't have the workflow in place, they're going to want to think about, their workflow. Are they ready for how that's going to affect their technicians and how they're going to utilize their staffing? I would think about PPE. If they don't have access to PPE, there's no way I would do COVID testing. State regulations and laws, PrEP. This is a pathway to professional development, so that's something I would consider. How you're going to clean everything. Make sure you're going to have, the proper cleaning supplies.
Yeah. So there's so many questions I've got in my mind, and we're seeing an explosion of questions from our audience, and we'll get to those soon, I promise. But let me dive in and nuance a few of these things out just a little bit. So when you do COVID testing, do you actually do that inside your pharmacy, or do you have a tent set up outside, or where exactly does COVID testing happen?
So we do drive-up testing. We have a tent set up, pretty good sized tent. You could park a car under there if you needed to. So we have the tent set up outside. I have a unique space in the pharmacy because we do not have healthcare. It's something I've tried to get here for almost a decade. About a year ago, I restructured some of the pharmacy, created about a 600 square foot clinic space. We have a couple exam rooms, a restroom, and an exit door. So we actually sealed off one exam room, a restroom, and the exit door completely for COVID testing. So it's sealed off from the rest of the pharmacy. We go out the exit door and use the tent outside. So everything's sealed off from the rest of the pharmacy. We can clean everything and keep it safe. But we do utilize drive-up testing, so there's nobody coming in the pharmacy.
Okay, so what tests do you do? We've seen on the news all kinds of different tests that are available. What specific test are you using in your COVID-19 testing? And if you don't mind, where did you get it? How did you access the test?
So that's probably the number one question I'm getting, is what tests are we ordering? We're not actually ordering any tests and bringing them in here. We are letting the laboratory handle that with the relationship we have with the lab. We are using the nasopharyngeal swab and using the collection. We are only collecting the sample from the patient. So this is just a typical nasopharyngeal swab. We collect from the patient and then we send it off to the lab. The lab actually does the test kit, and they use the FDA kit for COVID. So we are actually not ordering COVID test kits here at the pharmacy. That would be another step if somebody's doing that they would have to check with the Board of Pharmacy, the CLIA waive, if they were actually ordering test kits. But the laboratory is actually doing the test kits. We're just collecting the swabs and doing the collection process.
See, so it sounds to me like that this relationship that you had with the county health department, with the local laboratory that's doing everything, that the community really got behind you and supported you, and this has been a real collaboration, healthcare collaboration in your community to make this work.
It's been a collaboration with everybody. We had donations of masks from people in the community. We wouldn't have N95 masks if it wouldn't been for the community donating them. We have had people donate a lot of stuff. The fire chief got us our TICAM suits so we would have protection, and we can wash and reuse those until they expire. So it's been a collaboration from a lot of people.
That's great. That's fantastic. Well, let me dive into a few more questions here about the testing itself. Are your pharmacy staff involved in the testing procedure at all? Do you have student pharmacists involved, or pharmacy technicians or clerks or others? Or are you the one that primarily does the testing? Who's involved in the process?
So I have a staff of me, a fill-in pharmacist, and 4 technicians, counting my clinical technician, and we are all involved. I don't have a cashier, clerk, or anybody. We are all pretty much clinical staff, and we're all involved. Everything from taking patient data is hands-on. So the technicians help with gathering information from the phone call. We try to do everything over the phone so that the only hands-on experience with the patient is the actual collection. And the technicians do help me with, I do the testing, and the technicians help me with the packaging and all that stuff. So they help me from data collection, insurance collection, paperwork, all the way to the packaging and making sure the lab, everything's ready for the lab to pick up.
Okay, so it sounds like what you're describing is that if a resident of your community were to have the signs and symptoms of COVID-19, they wouldn't just drive up. They would actually be screened over the telephone. Is that what I'm understanding?
Everything's done over the telephone. We did have one event where we allowed drive up, but normal everyday workflow is everything's done over the phone. Yeah. Everything's screened ahead of time. Yes.
Okay. So the other thing I wanted to point out is that, we did talk about CLIA waivers up front, but you're using a laboratory to actually conduct your testing. So really, if you're using the model that you're using, you really don't even have to have a CLIA waiver for that, because the lab is fully CLIA certified. Is that right?
That's correct. But to do the antibody test, which I think is going to be the next step, you're going to want to have the CLIA waiver for. And I think that's going to be this isn't necessarily a big money maker. And there's not really a pathway yet because this is so new for reimbursement, but there will be with the antibody test. And I think that's going to be the biggest opportunity for us. So you're going to need a CLIA waiver for that.
So I'm just curious, Beth. I'm not positive that every pharmacy school in the United States is teaching pharmacy students how to do nasopharyngeal swabs. I think I learned how to do those when I was in practice at the county health department back in Birmingham. I'm curious, where did you learn to do nasopharyngeal swabs, and do you have recommendations for how a pharmacist would learn how to do a nasopharyngeal swab?
I actually took a course for the point of care testing probably in 2017. I took a course in South Carolina and me and my husband went together and took the course, and that's where I learned. We did sample tests with the flu and strep testing. We did pretty much all those things. So
Right.
You can find those, but I would highly recommend a course like that. It took a weekend.
And we could also perhaps suggest that if you're collaborating with the local health department, the public health nurses might be able to teach you how to do that swab if you need assistance, and others. So
Yes.
yeah, good, very good. Okay, well, let me ask a couple more questions. Boy, I'm enjoying the Q&A, and thank you so much. Let me go through just a couple more questions here. What happens if you have someone who tests positive? So the laboratory is getting this test. Maybe you could tell us, how long does it take to get a result back from the laboratory using this test? And then when you get the result back, what does the lab have to do and what do you have to do?
So this has probably been the most positive thing because the testing in our area is taking so long and people are having to wait for their results to come back to get back to work, and that it's taken 2 or 3 weeks. So when we did our first testing, we got them back in 24 hours. So we're able to get a quicker turnaround. So we're telling people 1 to 3 days, and we're able to get the results back. So that's making a huge difference. So if it's a positive results, the lab will let the health department know. We call the patient. So it's our responsibility to let the patient know. It's the laboratory's responsibility to let the state know. So they report to the state if we have a positive. We have a protocol, just like we do with any other point of care testing that we do, on how we follow up with the patient. That's going to be up to, I guess, each pharmacy on what they want to do. But we follow up at test results day 7 and day 14 with this particular test that we do.
So you make patients who test positive aware of the isolation recommendations from CDC. You make them aware of follow-up with emergency department if they have shortness of breath and those sorts of things. You pretty much follow the CDC's guidelines in terms of.
We do, and I don't know if you can see this, but we give out with every test. We give out the CDC recommendations, and we recommend that they don't work till they hear back on the results and things like that. But we give out CDC recommendations on hand washing, social distancing, all those things.
So if you get on the laboratory side, I suppose this is on the other side of the equation.
Mm-hmm.
If they find a positive test, do they retest that sample to make sure it's positive? So is it a confirmed positive? And
I believe so. I may have to get back with you on that, but I believe that's the protocol.
All right, great. So, so it sounds like as a pharmacist, you're taking responsibility for the patient, and the laboratory is taking responsibility for the public health reporting under the law.
Yes.
Okay,
that's
so
correct.
Great. Well, that sounds great, and it makes good sense to me that that's the way the process works. And that's an interesting approach, and I like the fact that you've got this protocol in place. Well, I'm going to ask you one more question. There's 100 more I could ask you, but our audience is chomping at the bits to ask you some questions. So I'm going to just ask you one more. What advice do you have for pharmacists as they explore starting to do this testing? What words of wisdom and advice do you have? Be real with us. Tell us the good, bad, and the ugly.
Okay, so As I was mentioning earlier, this is not a huge moneymaker right now, but I do think this is a waymaker for professional development. We've been screaming that we need provider status, and then here HHS comes out and hands us this on a silver platter. I think we should take this as an opportunity for professional development, as a gateway into the antibody testing that will come. I think we should consider workflow changes. I think we should consider using the appointment-based model. I think if you're not doing MedSync already, then that should be something you should consider in your workflow so that you have the time to do the appointment-based model. I think we should still continue trying to get provider status on a federal level so that we can get paid to do these services, just like any other medical healthcare provider, because they can certainly get paid, no questions asked. So I think we just need to keep pushing forward professionally, and collaborating with everybody. This what made this possible for me, not just on the healthcare community side, but with everybody in the community.
Great. So I think, Beth, one of the things that I've taken away from this that I think is a really important point for our listeners is that, there are different kinds of COVID-19 tests out there. There are some that are CLIA waived, and there's some that are not CLIA waived, or at least the one that you're doing wouldn't necessarily, because of the way that you're using it, require CLIA waiver. And so you don't have to let that be a barrier if you collaborate with the laboratory in the right way. So there's always a solution to a problem if we are creative and we approach this with creativity. It sounds like that's what you've done in your practice.
That's right. And I'm sure there's other ways you could do it. There just may be other steps you need to do with a CLIA waiver, or however you want to do it. There'd just be other steps.
Yeah, okay, great. Well, I tell you what we're going to do. I'm going to go off webcam, and we're going to invite Dan Zlott to join us, as well as Elisa Bernstein. And we're going to now open up our Q&A session. You can ask questions about the drug therapies. You can ask questions about Beth's practice. Anything that you want to ask questions about, we will take those questions, and I'll try to filter through these. We'll go back and forth, and APhA staff will open lines as we identify them. We've gotten lots of questions on lots of topics. Let's stay with Beth for the moment. And question from Leslie Heron, Herron. Leslie Heron. Staff, can you open her line?
The line's open.
Well, I think Beth touched on a lot of my questions.
Okay.
We are ramping up to do antibody testing, hopefully by late next week or early the beginning of the following week, and just really appreciate her insight.
Yeah, Leslie, what part of the country are you in, if you don't mind me asking?
I'm in Iowa.
Okay, great. So Beth, can you tell us about your timeline for antibody testing? Have you got that figured out just yet?
I will. To my knowledge, there's not any antibody tests available at the moment that have the proper emergency use authorization available to us to purchase. You can buy them, like I've seen where you can buy them, and there's companies selling those, but I'm kind of waiting for the proper channels to follow through with the emergency use authorization before we offer that. Just because I feel like they should have the proper channels.
That's great, and I'd love to ask Elisa Bernstein if she would like to just make a quick comment about the EUAs. We've talked about those before, but Elisa, would you like to elaborate on why those FDA emergency use authorizations are important?
Yes, hi, thank you. Yeah, so under the HHS guidance that was issued recently, it provided for pharmacists to order and authorize COVID tests, including serology tests, that the FDA has authorized. So it's not, and that is authorized under an emergency use authorization. And so that really limits those tests. And it shows that if FDA has reviewed the information and made a determination under the standards that are currently exist under the emergency, that this product is acceptable. And so it's really important if you're looking to do testing to make sure that it is one that can be used in a patient care setting and that there is an EUA authorized. And the FDA website has that information.
Okay. All right. You know, we didn't spend much time talking about personal protective equipment and testing and what's going on at Beth's place. She mentioned it a little bit. We have a question from Quaylon Lee, last name L-E. Quaylon Lee, would you like to ask your question?
Spell the last name again.
L-E.
I think he may have left because he's
Okay.
not showing up.
Well, let me ask the question, Beth. What kind of PPE are you using, and could you just reiterate again, where did you get the PPE?
Sure. So we had a lot of help with that. We had N95 masks that were donated from the community. We are using goggles, and I think I might have to get back to you where we ordered those. We ordered those. We had help with the fire chief. They helped us order those and the TICAM suits that we're using. And like I said, with those, what's really nice about those is we can wash and reuse those until they expire. And they're real simple to wash. You just use like Dawn dish detergent and wash those, brush those off and rinse them, and they're good to go. And then of course we use gloves, and I think that's pretty much it. Mask, gloves, or goggles. We also have face shields, but I prefer the goggles.
Okay, great. Well, thank you for that. All right, let's take a question about drug therapy. Cindy Warriner, W-A-R-R-I-N-E-R, you have a question about the study with hydroxychloroquine and azithromycin.
Cindy's line's open.
Yes. Can you hear me?
Yes, we can hear you.
Okay. I guess what my big question is, and obviously it was mentioned a little bit that these patients were kind of sicker patients, and I'm wondering if anybody has done any studies with introducing the hydroxychloroquine, azithromycin early in the phase. In other words, kind of like Tamiflu, whereas if you catch it within the first 32 hours, you still have the flu, but the course may be shortened and it may not be as severe. And I'm just wondering if anybody is looking at the days that the hydroxychloroquine, azith, or singly or in combination are being administered.
Cindy, that's a great question. So the answer is yes and no, like many things. No one is specifically testing for that in a study to see, do you have to catch it in the first 24, 48 hours, et cetera. However, if you look at a lot of the studies, and we just didn't have time to get into this level of detail with the studies that we talked about, but different studies have started hydroxychloroquine within different timeframes. So in the initial studies that came out from Gautret et al., that was more of the descriptive data, not the randomized control trials. They were very aggressive about starting hydroxychloroquine and azithromycin. And in those patients, the average start time from the onset of symptoms to when they started hydroxychloroquine was between 5 and 6 days. So still longer maybe than that 24 or 48 hour window, but they were pretty aggressive. Some of the Chinese studies, the average time from onset of symptoms to the initiation of hydroxychloroquine therapy was over 2 weeks. In one study, it was 16.7 days. So a pretty good variability there. And no one has really done a deep dive or a subgroup analysis in that to really see if it made a difference. The one Chinese study did a subgroup analysis, but their categories were less than 7 days, 7 to 14 days, more than 14 days, et cetera. So a pretty wide window. So people are looking at it a little bit, but not to the level of granularity that you're talking about. And I suspect, as this continues, we will see additional trials come out once we answer some of our main questions about does it actually work, to see if there's a time frame that therapy has to be initiated within.
All right, great.
Thank you.
I want to
Thank you so much.
I want to take a comment now or question now from James Kong, C-O-N-G. James Kong about the collaborative practice agreement. This is aimed for Beth.
Line's open.
James, your line's open if you'd like to ask your question. Okay, we can't hear him. I'll ask his question for him. Does your collaborative practice agreement require that the patient has to be established with the provider that signed the CPA ahead of time, which means you'd only be able to test specific patients? Maybe you could just clarify real quickly how I think if I heard you right, you really don't need the CPA to order the test. You have the independent authority because of HHS to actually order the test. Is that right?
That's correct. So we did not end up needing the CPA. When we were in the process of doing the CPA, we had thought about that, and we had included in the CPA that we would refer, if they did not have a primary care provider, that we would refer them to one.
Okay.
So
great.
we had thought about that, but we did not end up using the CPA. We did not need it. And
Okay.
then just to follow up on the question before, we ordered our TICAM suits and goggles from a company called Airgas, just in case that person's still on the line.
Okay, great. All right, let me ask Michael Manolakis to ask his question.
Michael,
Michael, your line's open.
thank you, Michael. Thank you, Beth. Beth, are you collaborating with your local employers at all as it pertains to their return to work policies and protocols? That's my question, and thank you.
We do collaborate with the local industries. We have a pretty good size industry park down the road that we do their immunizations for, and that's when the antibody test will come into play. And they are very interested in the antibody test, so that's where we're going to utilize that relationship.
Okay, great.
Thank you very much.
I'm going to ask Mamatha Rothu, R-O-U-T-H-U, to ask your question. And what I'd like is that this is a question about liability. And I'd like first to have Elisa Bernstein, as a pharmacist and an attorney, to talk about liability of testing. And then I'd like for Beth to also answer about her perspectives on liability. So Mamatha, would you please ask your question?
Mamatha, your line is self-muted, so you need to click it on your computer.
Okay, Mamatha, are you able to speak, to ask your question? Okay, not hearing you, I'll ask it. The question is, how safe is doing this testing for the pharmacist? So there's a safety question. And then if something happens, a pharmacist becomes infected or staff member, who takes the liability for that? So Elisa, as a pharmacist and an attorney, would you address that first on the liability side? And then I'd like to get Beth's opinions about it.
So that's a good question in terms of liability. It depends. It depends on what state you're in for that type of liability. What the HHS, the HHS guidance did when they issued it triggered coverage for liability for ordering and administering the test. So there's immunity for liability for ordering and administering the test for pharmacists, licensed pharmacists who are doing it according to if there's an EUA in place and it's an authorized test. It doesn't speak to liability if somebody gets infected. So that typically you'd have to look to what the state law is in that situation.
And would that be potentially a workers' compensation type claim, Elisa? Would that be a correct?
It could be. Yeah, it could be.
Yeah, okay. Beth, how did you take into consideration safety of your staff and so forth? You mentioned that you would have not done this had you not had appropriate PPE. I think that was one key thing I took away. But what other things did you think about from safety and liability?
I think education's very important, and then following protocol. It has to be a very set protocol on how you dress, how you clean up. You know, we have a clean space. We have work clothes and we have clothes we change into when we go home. We all have young children that range from, I think the oldest one's 11 down to a few months old. So we take this very serious, and I think everyone should. I think it's a real risk, but I think, you know, what we do every day is a risk. So I think education and protocols and following those to a T every day. So it's just like everything else we do.
Yeah. Okay, that's great. Well, we have got probably a half a dozen or so questions about money. So I'm going to actually take liberty to ask a singular money question on behalf of all the people who've asked questions about the financial aspects of this. And I also want to say that in order to protect everyone on the call from antitrust regulations, that we can't talk about specific prices and pricing on today's call because that would be against federal antitrust. But what we can do is talk in general terms about how you receive payment and how the insurance coverage for COVID-19 testing works. And so maybe you can talk about that in light of your current COVID-19 testing and then your future view of antibody testing as well in terms of insurance billing and payment, whether it's cash or otherwise.
Okay, so for us, this is a community service. A pharmacy, the lab handles the billing. This is a service that's covered by insurance. If patient has insurance, this is a billable service that the insurance will cover. The lab handles all the billing. A pharmacy could charge a administration fee or a service fee if they wanted to, or a facility fee, however you want to call it.
And let me interrupt you. Is there a limit on the amount of money that can be charged, or is that to be determined independently by the provider?
That would be to be determined independently, but I would not charge a whole lot for that fee because they could go anywhere and have that completely free of charge because this is a covered service under insurance. And the administrations have made sure that this COVID testing is a covered entity for people. They made that clear. They want COVID testing to be covered for people. But I think it's just really early for pharmacists to be able to do this, and there's not a way for us to bill really on the pharmacy side. I think it's something we'll figure out. It's just so early right now. I think the payment model is going to be with the antibody testing. As far as I know, that's going to be a cash pay. So I think that's something employers will also pay for and be willing to pay for to know that their employees are safe to come back to work. So I think the payment model is going to be with the antibody tests. So that's really where I think we'll make our money. But as far as, I don't think this is going to be a huge money maker. I think this is more of a professional pathway, and that will lead up to the antibody testing.
Okay. All right. Great. Well, I tell you one thing we're going to do real quickly because we want to get some insights. We've got a polling question we'd like to ask everybody on the call to take just a second and answer. As a participant in today's call, I'm interested in performing testing for COVID-19 in my community. Yes, no, or not applicable to my position. Let's just take a few seconds, and if you'll respond right on your screen so we can get some results here. I'm curious to know how many of you are really interested in doing testing in your community right now. And so let's take just a second more, getting a good response rate here. And great, thank you all for being quick on the buttons here and clicking through and getting your votes. This is wonderful. Okay, just a couple more seconds. All right, Brian, let's go ahead and give the results. And it looks like about 42% of you plan to, about 47% of you are in positions where you're not able to make that decision or it's not applicable to you, and about 11% said no, you don't plan to do the testing. All right, well, we have a lot of good questions and we weren't able to get to all of them today, so we will use these questions and try to answer some of them. I want to let you know that we've got some resources available to you and some ongoing activities that you need to be aware of. First of all, If you'd like a little deeper dive on hydroxychloroquine and the information that Dan shared with you today, we have 2 CE programs that are 15 minutes, about 15 to 20 minutes each, that are now live on Pharmacist.com as part of APHA's 15 on 19, and we'd encourage you to take a look at those. Real quickly, I want to ask Elisa Bernstein now to share with you a couple of advocacy things that are going on at APHA related to coronavirus. Elisa?
Sure, thank you. So the coronavirus has continued to keep us very busy at APHA. Pharmacist safety continues to be one of our top priorities. In the last week, we reached out to DEA asking them to provide flexibility and not require a physical signature for the sale of OTC pseudoephedrine. DEA continues to say that pharmacies should offer gloves or wipes for people to for sharing the stylus, and that just doesn't make sense in this day and age, and we're hoping that DEA will change that. We continue to work to on all fronts to facilitate and implement a pathway for all pharmacists to conduct testing for all patients. We're continuing to work on different issues related to the logistics and payment and billing, some of the issues that you heard here today. In compounding, FDA continues to provide flexibility and discretion in the compounding arena to ensure the availability of medications that are necessary to treat patients during the pandemic. Just recently, in response to a request by APHA and other pharmacy organizations, FDA announced that pharmacies can compound certain medications for hospitalized patients without patient-specific prescriptions to address COVID-19. Don't just start though. Read the guidance so that you can learn, because there are certain issues that you need to address before you could do that. And then finally, well, not really finally, but the last thing that I wanted to highlight here for you is that we revised our joint statement with AMA, ASHP, and APHA regarding inappropriate prescribing and dispensing of medications. What we did is we basically added some new information about the need for evidence-based science and practice to inform decision-making about the use of these medications. So you can go to our website to find out more. For the sake of time, I'm going to just move to the next slide and just let you know we have, APHA continues to develop practice resources or kind of short, quick reading for you that's highly informative. We have 18 so far, and we continue to issue these almost on a daily basis. But what we've highlighted here are 4 practice resources that are related to the topics that we discussed today. So go to our coronavirus website, the Pharmacist Guide to Coronavirus, click on where our practice resources, and you can see the menu of options and information that we have. Finally, oh, go ahead. You're on the next one. Go ahead, Michael.
No, thank you very much, Elisa. That's great information. And I want to remind our listeners that we at APHA have the Engage platform. And one thing I want to point out is that one of our pharmacists on staff has provided a wonderful update based upon some questions that were asked on last week's webinar related to how to reuse masks safely, how to sterilize them, clean them, and to be able to reuse masks. And I'd encourage you to go to the Engage profile and take a look at that information. Really great information. And if you're plugged into Engage, you can post your questions, share your lessons learned. You can support each other and get the latest information from week to week. And I would just like to ask all of you, if you are planning to test or starting to test, share that with your colleagues on Engage. Let us know, because we want to hear your stories, just like Beth Bryan's story, so that we can share those broadly in the profession and help advance our profession. Now, join us next week at the same time and same location. Next week, our plan is to share with you some more information about drug shortages and pharmacist compounding to be able to resolve those drug shortages. Of course, we will preempt any topic we planned on with any late breaking news that might happen that would be relevant to you as pharmacists. Thank you for joining us. Thank you for all that you're doing for our profession, and God bless.